interested in that, there is more information at the back table on the mental health first aid program. And so why are we here today? We are here again during Mental Health Awareness Month to bring awareness, education, and information to our community. Recently, Polk Vision and many partners engaged in a Polk Vision behavioral health study, as we know that mental health continues to be a priority in our communities. So we partnered in order to provide you with additional information and education. And what you're going to hear today is information that came from that study, findings from that study, and then the content for this program was specifically chosen, questions and the topics specifically chosen to provide you with the most pertinent information to answer questions and give you resources and guidance. Again, our purpose with our education at Peace River Center is to help bring awareness and education to mental illness and topics surrounding stigma and anything else that prevents us from seeking the care that we need or creating understanding for individuals who are living with a mental illness, a severe and persistent mental illness as well. So I don't want to take any more time, but I know that you're going to find everything that we provide to you with a lot of information. There's information in the back from our participant partners. I want to welcome everyone on Zoom for being here today. I do want to recognize that we have probably over 100 individuals via Zoom today and over 55 individuals here today. So thank you all so much for making this a priority. I want to now introduce Alice Nuttall with Lakeland Regional Health. She's going to provide an introduction to Scott with Crescendo, who helped find the study. So Alice.
Good morning, all. As she said, my name is Alice. I'm the Associate Vice President of Behavioral Health at Lakeland Regional. And I just can't tell you what a joy and delight it is to be here with all of you fine people. First of all, we're together. We have been talking about this for several years as a county, but coming together seems really monumental. I have the honor of introducing Scott Good. Scott Good crossed paths with the Polk Vision behavioral health team about 2 years ago. We were looking for someone to really spearhead our strategic plan and systemic intercept map project. And the thing about Scott, he's from Maine, but he was raised in South Florida. So he's a Florida boy deep down, but also he's an amazing statistician, auditor. He's really wicked smart with numbers, but Scott also understands the heart of why we are here and has always understood the heart of our project. So Scott, thank you so much for all the help that you have done here at Polk Vision, helping us develop the strategic plan. And now you can help us celebrate seeing that work come into fruition with conversations like this. So I'll hand it over to Scott.
Thank you very much, Alice. It's a delight to be here, just delightful. And you know, we have the opportunity to do planning and research, and that's all well and good. But what's really important, why I think we're all here, is that the numbers and the research and all that, it's nice up to a point, but those don't change anything. You all change things. So you came out today, another 100 online who are here too, not just to hear things and hear some statistics or whatever, but to ask questions, to move forward and to make change here in the area. So this is very exciting. I'm just delighted to be here. And I do have a little bit of background to share with you. This won't take too long. These are the experts here, and I used to be a teacher, right? So over the next 15 minutes, I want you each to think of one question you're going to ask these panelists. So we've got 6 hours here, right, for the panelists? Okay, just making sure. Okay, let's see, clicker. I love technology until I don't. Let's see here. Well, we seem to, okay. Turn it off and back on. Off, back on. Well, imagine if you would, a new slide. Okay. Okay. There we go. Okay, so you'll be advancing them? Okay, that's fine too. Okay, so there really is a story to tell. And like any good stories, there's at least a little bit of fact. There's a lot of fact in the foundation of this story. So a few things I'd like to share with you. There's growth. There's a lot of growth here, 13%. 2010 to 2020, but along with that growth, The provider base is smaller here in Polk County than the rest of the state. Baker Act examinations have increased dramatically. You all know that, you've seen it. And the thing that I found particularly interesting is that the acuity, a quarter of those that are Baker acted once get Baker acted multiple times. So it's a small but very highly acute sub community, if you like to think of it that way. If you look at the next slide, there's a few more things sort of as an overview. There's some good news too. High school graduations have increased dramatically, almost doubling from, I think it was 2006 or 8 to 2021, especially among Black and African American and Hispanic communities, up even stronger. Also, look around the room. It's not just one organization that's here. There's several, there's many. Polk Vision is an amazing resource, but they're joined by Lakeland Regional Hospital, Peace River, Department of Health, the Sheriff's Office, Heartland, so many others that are here. And to see you all show up, get ready to roll up your sleeves and go forward, it's really it's very encouraging to me, certainly. And it should be to you as well. On the next slide, there we go. Along with the pandemic, there's a lot of high risk, different communities, a lot going on there. At greatest risk, the low income, single parent families, Black households, kids with disabilities. This is a surprisingly large number. Okay, next slide. Okay, a few more statistics. I don't think I need to bring you through each one of these, but it's very sobering. One in four parents of young kids 5 to 12 said that the kids were experiencing overall worsening mental health over the past couple of years. A quarter of teenagers lose sleep because they're worried or they're unhappy or they're depressed. That's more than just a teenage thing. This is an issue. I've had teenagers, and so I know what that's like. But I've also observed that it's different now. It's very different now. We had a discussion group during our project a year or so ago where we spoke with high school kids, and we asked them, what about social media? Is it a good thing or a bad thing? They said yes. It's both. But I think that during the pandemic period, that really exacerbated things that were vulnerable during that time. Okay, the next slide, please. There's a lot of tragedy, which we hear about all too often. One completed suicide is one too many. Okay. The thing that really stands out, I mean, all of this is sobering, but 11.8%, so 1 in 8 kids made a plan as to how they would attempt suicide. Okay. There's no sugarcoating that, there's no getting around it. This is a very serious issue. And that's why what you're doing here, it's nice to get together and it's nice to have these talks, but you're saving lives. You're in a position where you can impact and save lives. So I'm personally very grateful, and I'm sure that the community is really relying on us together to try to make a difference here. Next slide, please. Nationally, the rates of completed suicide are up about 20%. We've seen some pockets where it's up 60 and 70%. Okay, it's heartbreaking, right? It's heartbreaking. But go to the next slide. Here locally, it's a lot of kids, 150,000 kids plus. A third of them roughly have struggled with anxiety and depression to some extent. Wow, these are big numbers. And remember, you can't do everything for everybody, but you can do some things to save some lives and to change a whole lot of lives. So that's some of the things we're going to be talking about here. Next slide, please. A few more statistics, and we'll move on from this. Emergency department visits for kids, young kids 5 to 11, increased by 20%. There's fewer providers per capita in Polk County than the state in general, and certainly the US, a third per capita, roughly, versus the US average. Suicide rates, we've talked about that. The next slide. But there's good things happening. There's a lot of conversations like this happening, not everywhere, but in a lot of places. There's things like the Children's Mental Health and Emotional or Behavioral Disorder Project. It's a national project that's getting some traction to address some of these needs. There's things like The Recovery Research Institute, I'm not sure if you've heard of that or not. It's an organization up in Cambridge, Mass, I think. They're doing amazing work on residential care and transitions of care for people experiencing homelessness, but those with mental health challenges as well. And the good thing is they have like 12 years worth of data, really good data. So they're one of those shining stars that we've been aware of for a long time, but they're getting more active and their work is becoming, along with others, becoming more pertinent to what's going on today. Next slide. Nationally, some schools have already seen a large increase in social workers, 17% increase in counselors relative to before the pandemic. And one of the reasons why this is particularly important is because it's nice to have the counselors and the resources and the facilities, but those are sub-optimized if you don't have a counselor or you don't have somebody to bridge that gap. Okay, just having the capacity isn't enough anymore because people don't know about it, they're not aware of it, it's not delivered in a culturally sensitive way. There's these other challenges that, whether it's social workers or community health workers, they can help fill those gaps and make the whole process work more efficiently. So in any particular town, maybe you don't need 20 more counselors, maybe you need 3 more, but you have to have the other 17 work more efficiently. And there's ways to get that done that are more budget friendly, that help the whole process. And back to why we're here, to improve the lives of kids, families, and to save some lives along the way too. Okay, the next, there we go. So how do we bridge the gap from where we are to where we want to be? 3 bullet points, that's all. Can't be that hard, right? So let's just break down all the silos. I guess that's not quite as easy as it sounds, but that does take a lot of work. And again, I can't overstate this. I'm really encouraged to see you all here. But breaking down silos, it's got to happen. It probably won't happen 100%. That's okay. Don't let the good be the enemy of the perfect, okay? But there's things you can do to help make that work. Engage diverse communities and engage the needs where they exist. A top-down approach to providing mental health care doesn't work. Not entirely, it's helpful, but to engage those local communities, those high-risk communities in their own community's welfare. That's how you're going to engage those trusted resources. And that's how you're going to optimize what you do in your work. Enact focused youth interventions. Who here has 27 things on their to-do lists for next year? Probably not many, okay? Well, you might, but you're probably only going to really get at 3 to 7, okay? So you have to refine and focus what we do. And that is complicated by trying to work together to do those 3 to 7 things. But you're here. You don't need to do everything. And if you're Peace River, you don't need to be involved with all 7 projects. Maybe your part is just in 2 or 3 of them. If you're Lakeland Regional, maybe you can lead 1, support 2 others, and be a cheerleader for 3 others. And that's fine too. Whatever role you have, realize that it's a group of projects working together to make a change. Okay, next slide. Okay, I'm juxtaposing Dr. Seuss and Aristotle here. Okay, first time ever, I think, in history. But the keys to success, I'm going to read this from Aristotle here. Excellence is never an accident. It's always the result of high intention, sincere effort, and intelligent execution. It represents the wise choices of many alternatives. Choice, not chance, determines your destiny. Makes sense. And Dr. Seuss says, sometimes you'll never know the value of a moment until it becomes a memory. If you have a notepad, write down today's date, okay? Keep your notes, because this day will never happen again, okay? And this can be one of those important days that starts to make a difference, okay? So with that said, I think that's my last slide, isn't it? I think it is. So what I'd like to do now is introduce Teri Saunders. Teri is the, excuse me, Chief Executive Officer of Heartland for Children. I think you all know Teri. So please welcome her and enjoy the rest of your morning. If there's anything I can do to assist or answer any questions, feel free to grab me at any time. Thank you and good morning. Teri.
Thank you, Scott. We very much appreciate you being here this morning. Thank you. And I love the juxtaposition of Dr. Seuss and Aristotle. That was great. Okay, so I have the honor and privilege this morning of being the moderator for your panel. And I'm going to introduce our panelists and then dive right into a number of questions that we have. And hopefully at the end, we will be able to get through all of that and have a little bit of time for some question and answers as well. Not 6 hours, as Scott had mentioned, but some time to cover just some basic questions. Let me get some things organized here. Got a few too many things on the podium, if you don't mind. Okay, so I'm going to introduce our panelists. First, we have Dr. Christie Olson with Polk County Public Schools. Christie currently serves as the Senior Coordinator of Mental Health Services with Polk County Public Schools. Dr. Olson is a licensed mental health counselor, a certified youth mental health first aid trainer, and a certified trainer in NASP's Prepare model for school-based crisis intervention. Dr. Olson assists in delivering various training, including suicide and threat assessment, to Polk County school staff. As a senior coordinator, and she supervises 35 mental health facilitators who support students at risk throughout Polk County. So welcome, Dr. Olson. And sitting to her right is Tiffany Fritz with Peace River Center. Tiffany is a licensed mental health counselor and currently serves as Director of Children's Services at Peace River Center. She earned her master's degree in professional counseling with a concentration in marriage and family therapy from Southeastern University. She has additional training in infant and early childhood mental health, EMDR, and adoption competency. Tiffany is a certified trainer for adult and youth first aid mental health, and she also partners with law enforcement through the Crisis Intervention Training Program to share how mental illness can present in a child. Tiffany is the chair of the Circuit 10 Child Abuse Prevention and Permanency Local Task Force and the Circuit 10 facilitator for the statewide inpatient psychiatric program, helping families navigate the process of pursuing residential treatment for children. This focus is to help clients and their families understand the impact of trauma as well as hope for healing. Welcome, Tiffany. And next on our panel is Dr. Simon Chamakalaya. I knew I was going to mess that up, so thank you. And he has graciously allowed me to refer to him as Dr. C. So Dr. C is a psychiatrist at Lakeland Regional Health. He earned his Doctor of Medicine degree from Drexel University College of Medicine in Philadelphia, Pennsylvania, and completed his residency in psychiatry at Temple University Hospital in Philadelphia, where he was chief resident. Dr. C also completed a fellowship in child and adolescent psychiatry at MedStar Georgetown University Hospital in Washington, D.C., and served as the clinical fellow. Clinical chief fellow. I don't want to shortchange you on that. His professional interests include treating children, adolescents, and adults in a variety of settings, as well as community outreach for mental health. Dr. C is double board certified in general psychiatry and child and adolescent psychiatry by the American Board of Psychiatry and Neurology. And he is newer to Polk County, so please give him a warm welcome. Okay, so to kick us off this morning, I wanted to ask you, Christie, if you could kick us off and share your opinions of what are the most pressing concerns affecting youth today.
Sure, thank you. Our youth today are experiencing some challenges that we in previous generations did not have to face. I'll start with social media. Let's look at how attached kids are nowadays to their phones and to any type of social media. They spend an average of 9 hours every day on social media. And what does this mean for them? It means they're not as able to interact with their peers. They have increased exposure to cyberbullying, increased feelings of envy and inadequacy, increased pressure to constantly show their self in the best light. How many of you have children whose kids have cell phones and they have tons of filters on there? Do you know they have filters now to help you whiten your teeth? So the pressure to constantly be perfect in social media, to post pictures that are perfect, to show that you are in the perfect place where the most popular kids are. So social media is increasing all of that anxiety with kids. It is impacting their sleep. It is impacting the time they have to do their homework for academics. Then let's talk COVID. Just combined the impact of social media and COVID, the isolation that kids have from that, the loneliness. So you have that isolation and that loneliness, which is leading to increases in depression and anxiety for kids. They're coming back to school and not necessarily knowing how to socialize like they did before. According to the National Institute for Mental Health, 15% of teenagers may develop depression before reaching adulthood. That's a large number. Some other concerns that we have, in addition to that, are school violence, drug and alcohol abuse, vaping, single-family homes. I mean, the list could go on and on. Basically, 1 in 5 youth are going to have a mental health disorder that significantly impacts their development. And when I say significantly impacts, I'm saying that it will affect their ability to live, laugh, love, and learn.
Okay, thank you, Christie. You know, we all know, and the research is out there and tells us that feeling safe and accepted are cornerstones for child development. And all of the things that you're talking about are things that put additional pressure on youth today to feel accepted. And we know that that challenge in our fast-paced world is just, sometimes it outweighs the resiliency of those youth. And so we really want to talk a lot about today about what we can do to build that resiliency, what we can do to help families whenever children are at that place where they're experiencing a mental illness. And so I want to shift a little bit to you, Tiffany, to talk about what the research tells us about the onset of illness in youth, those symptoms and identification. And specifically, can you talk about positive and adverse childhood experiences and how these correlate to children's mental health, and describe ACEs and the correlation to children's mental health and some of the early childhood development?
Sure. So we might need to make it 6 hours because there's a lot that could be said. I think I could spend this whole time just talking about ACEs. So when you think of the term ACEs, you're thinking about adverse childhood experiences, right? This is a very layered concept. So bear with me as I try to unpack it. So when you think of childhood, we all have moments that are hard, right? What we all do. If you think back through your childhood, you've gone through hard things and you've survived them because you're here today, right? So adverse childhood experiences are not childhood trauma, right? They are not. It's different. You're thinking about specific experiences that someone has gone through in their childhood from birth to 17. And this could be a lot of things. It could be abuse. It could be neglect. It could be experiencing an environment where there was domestic violence, or there was someone in your home that was violent towards you or to someone else. It could be having a sense of food security, where you go home and you don't know if you're going to have enough food. You go home and you don't know if anyone's going to be there to keep you safe. There's lots of things. If you go on the CDC's website, they have a list of these are all of the designated adverse childhood experiences, and there's several. And when you look, it really boils into two different pots, things that have happened to you, and then the atmosphere, the environment, right? Sometimes it's having a caregiver that has a mental illness. Sometimes it's having a caregiver that has a substance use problem. Sometimes it's having someone in your close family that's been incarcerated. So a lot of things that really build into affecting your sense of attachment, affecting your sense of security, your sense of stability. And when we look into the environment, a lot of times you may be thinking, well, there was domestic violence, but the child was never the target. There was this going on, but the child was never directly affected. Think back to your childhood, right? Your primary caregiver, maybe it was a grandparent, maybe it was a parent, maybe it was an aunt or an uncle. When their sense of safety is affected,
your sense of safety and security is affected. So it's completely connected, even if that connection doesn't seem very apparent. So these are different adverse childhood experiences, right? So then there was a study that the CDC has posted that said, I think 25 states were surveyed, and they said of the people surveyed, 61% of people expressed, yeah, I've experienced an adverse childhood experience. And I think if we surveyed this room, I can tell you I have. I think most of us had. And the study went deeper and it said, well, what about more than one? And the research showed that 1 in 6 people affirmed that they had experienced at least 4. What does that mean, right? Because it's not a direct correlation to childhood trauma. We all go through hard things. Here's the question: how does it impact you? As the director of children's services, many, many times we have children that we serve that experience childhood trauma. In fact, every single child that we open to services, we screen for childhood trauma. And sometimes it's a situation where it has a pervasive effect, right? It is impacting every part of their functioning. And sometimes there's a situation that happens and we think, well, are we sure that they went through this trauma? Because they really don't seem to be affected, that they really seem to be functioning okay. Why? Well, you have to look, you have to break it apart a little bit. I told you 6 hours. So when you think of childhood trauma, you think of risk factors. Like, what is something that kind of stacks the deck for some people and not for others? And then you have to think of protective factors, right? What are some things that protect you and kind of shield you away from the repercussions of what you go through? So risk factors, I think that you did a wonderful job really highlighting the risk factors. So thank you very much. Low income, right? Lack of education, lack of transportation, lack of access to care, lack of understanding mental illness. We were just talking before the panel started. I'm from North Florida. I can tell you, I did not grow up learning about mental health. I did not grow up learning about mental illness. People were the way they are, and that's just how they are, right? And there were no questions asked after that. And I think when you think about the risk factors, they're all around us. They really are. Single parent families, medical conditions, all of these types of things that really stack the deck to create obstacles in your way. Then you look at protective factors. The people in this room today are protective factors. Having a coach, having a teacher, having billboards when you drive to school and you see, call this number if you need support, having a doctor's visit where you go in and before you see your PCP, they screen you for depression in the lobby, right? And those surveys that they fill out, all of those things are protective factors. Having lunch provided by the school during the summer, those are protective factors. And I think when we think about ACEs, so many times there's this overwhelming feeling of, I cannot do it by myself. And you're right. So we have to shift this perspective from an individual responsibility to a community responsibility. We are in this together. I could not do this without Peace River Center. We could not do this without the school board. We could not do this without Heartland for Children. Everybody in this room, we could not do this without you. You play a vital part. And if we're not all working together, there's going to be a gap. So when we think about attachment, we talked about before those risk factors, right? The adverse childhood experiences. It's so important when children grow up that they have this sense of connection. They have this sense of attachment. And if they don't have that, then later on you see issues with emotional regulation. You see issues with ability to develop and cultivate and maintain relationships. And so I think it's this very pervasive issue where maybe it starts in childhood, but if we don't provide that sense of resiliency, then it can continue on to create childhood trauma. And when we think of toxic stress, we've all been there, right? That sense of hypervigilance, that fight, flight, or freeze. I do trauma-informed training for all of our new hires at Peace River Center. And one of the things that I always say is when you're in bed at night and you hear the ice maker and every hair on your body just goes up and you can tell yourself all night long, it's just the ice maker, just relax, just relax, just relax. The body does not understand the difference between an actual threat and a perceived threat. So if your body is having that toxic stress where you're always on alert, you're going to get run down. So we see whenever there are, high levels of adverse childhood experiences, there's issues later on in life. There's issues with chronic medical conditions. There's issues with, relationships. There's issues with education and job performance and earning potential. And all of these things are impacted by the presence of adverse childhood experiences if those protective factors cannot help adjust the course that child goes down. Did I hit it?
You
All
nailed
right.
it. Thank you. So Dr. C, what is the average onset of a serious mental illness? And how young, describe how young children can present with mental health concerns such as depression, anxiety, or obsessive compulsive disorder?
Sure, of course. So in terms of mental illness, just to give you a little bit of background, we see it as a two-hit hypothesis. What that means is there's a biological tendency to it through genes, DNA, and then a trigger for it. Now that trigger could be environmental, it could be something that's going on. Oftentimes we won't even know exactly how to pinpoint what that trigger is. But just like Tiffany said, it could be ACEs as well. So all these things could be triggers. So the literature tells us that depression and ADHD can present as early as 3 years old, but that doesn't mean it can't occur before it. It's just that at 3 years old, there's enough behavioral interaction, social interaction that we can make an accurate diagnosis. And obviously this is always done only after full medical evaluation, make sure nothing else is concerning. Anxiety can present at different times in different people's lives. Oftentimes we'll see separation anxiety as early as 4 or 5. Overall, the mean onset of most anxiety disorders is about 15, but realizing that's the mean, which means it can be a lot before and after as well. Anxiety disorders like agoraphobia, obsessive compulsive disorder, PTSD, generalized anxiety, those oftentimes we think of coming a little bit later on, but by later on, meaning in adolescence or later adolescence. So again, these disorders, these concerns come up pretty early and can be quite problematic.
And I'm going to stick with you, Dr. C. Can you discuss what the differences are between a diagnosable mental illness versus the need for behavior changes? And what types of diagnosis would a child in your care present with?
Sure. So when we talk about a diagnosable mental illness, it's something that affects the child in more than one domain of life. By that, we mean, so we all have domains of life. For adults, typically it's family, social, work. For children, it's typically family, social, and school. So if they're having difficulty functioning in 2 or more of these domains consistently, then and the reasons are about the same, then is when we diagnose them with a major mental illness. Those in need for behavioral change may not fit criteria for an actual diagnosis, but they can still absolutely benefit from counseling and coaching in terms of better coping skills and adaptive skills.
Thank you. And Tiffany, drawing on some of your specialty training and experiences, your adoption competency, your infant and early childhood mental health services and family therapy training, can you share from your perspective the need for behavioral changes compared to diagnosable mental illness?
Sure. So as Dr. C was mentioning, you really want to see, disruption in your ability to function. Well, that happens with us all the time, right? We have a rough day and we go home and we do the things that we know to do that make us feel better. We do the things that we've been trained to do, sometimes the things that we've been told not to do. Why do we do what we do? We want to feel better. And I think that's just being alive. Kids don't know automatically how to feel better. They're watching what you do. They're watching what's on social media. I was telling Teri in preparation for the panel, we all met together and we're talking, and I was talking about how I'm so glad that I've been able to learn what I know, because it's helped me even with how I relate to my own children. I have a daughter who is just like me, for better or for worse. And sometimes she'll come home and she will be in a mood. And my initial instinct is, oh no, right? Don't talk to your mother like that. And she's only 7. And so she's still learning. And so I'm so glad that I know what I know, because instead I say, you look like you're having a hard day. Let me help you find a way to feel better. And so I know whenever I'm having a hard day, I love having a bubble bath. I love having a good snack. I love just decompressing. Why would a child be any different, right? We give ourselves grace whenever we're snappy or whenever we're having a rough day. Where's that grace for kids who have less coping skills, who have less experience learning how to regulate? And so I will make her a bubble bath and I will say, you know what? I want you to relax and I want you to enjoy this time, and we're going to start over. We're going to have a great day. And I think I model that ability to regulate for her so she can learn, because we automatically expect people to know. They don't know. How would you know unless somebody taught you, right? You wouldn't. And I think sometimes it's through trial and error, it's through accountability, it's through I act like this. Is there any repercussion to my action? And so that's why it's so important that we have structure, that we have accountability, that children know what to expect. Every day I wake up and I say, all right, let's talk about our day today. This is what we're going to do, right? This is the plan. Whenever we pick you up from school, this is what's next. And I think creating that sense of structure and that sense of expectation for kids gives them a sense of safety, because they're part of the plan. Imagine how you would feel if you wake up and you have no idea what's going to happen. And, you know, everything that happens to you is at the whim of someone else, right? Just because you're 7, those feelings are just as real as if you're a grown up. So part of it is having an expectation of understanding that they're humans, right? They're people that are still learning. And the other part is taking on ownership of the responsibility to teach them how to regulate. So just because someone might not have a diagnosable illness, they still have feelings. And sometimes those feelings are very, very big. And learning how to teach them how to regulate those feelings, I think, goes a long way.
Yeah, and I think as you're talking, I'm thinking about, you know, all of our children in the foster care system and our children that have been adopted from the foster care system, and how important it is for them to have someone who has that regulation, that emotional regulation, and that ability to slow down and get in relationship and really connect with those youth to help to build their resiliency. We know that relationships are so important and in all children, right? And relationships with safe, stable caregivers are important for every child to meet their full potential, but more so in children who have had multiple adverse childhood experiences. That's where we need to be able to step in and fill that gap and help to teach and be intentional about that teaching of emotional regulation and how to slow down, how to offer redos to children, right? There are a lot of great opportunities out there. And I know we'll get to resources in a minute here and start talking about some of that, to just be able to point people in the room today to that, or people who are online to some resources. But before we do that, Tiffany, can you talk a little bit about what types of diagnoses a child in your care would present with, and what happens if a child does not have a diagnosis? Is there still help
Sure.
available?
Yeah, absolutely. So I think that across the board, what we probably see very similar diagnoses in what we do. I see a lot of PTSD. I see a lot of anxiety and depressive disorders, especially since COVID. I know Christie is going to talk more about that later on, just how we've seen the impact, but a lot of anxiety, a lot of decreased socialization, even in younger children. I have a 5-year-old who's starting kindergarten in the fall, and he's been in BPK this year. And across the board, we've seen a dip in socialization and interaction with other kids, even in speech, right? Forming words, because for the most part, we've been wearing masks for 2-3 years. And so you just see the impact that's kind of, pervasive. But I will say a lot of what I see results in trauma, unfortunately, and depression and anxiety. And I will say what's been really helpful for me is getting the caregivers on board, right? Getting the family on board. We are always in the school. Christie is one of our favorite people on the planet, because she has allowed us to coordinate with teachers. And so we're all a team. And I think, if you talk to any child and to work with a child, unless you have that reinforcement all around that child, you're not going to get the traction that you want. And so the best progress, I think, is when everyone's working together and creating that same expectation, reinforcing those same coping skills to where that child feels that repetition of safety and healthiness, because normal doesn't equate to healthy. So what we have to do is go in and change what is normal for that person. And that takes time.
Okay, thank you. So I'm going to shift the conversation to one of the most concerning topics that needs to be a part of any discussion on youth well-being, and that is suicide prevention and intervention. I know, Scott, you provided us with some good statistics to give us some benchmarks on how we're doing here in Polk County, and this really does look like an area where we need to lean into to help our community. So Christie, can you kick off this segment of the panel and talk about suicide rates in the county, how that they've increased consistently over the years, what you've seen a shift in that may be a factor related to that, and What do you know about suicide prevention and intervention?
Okay. As she said, Mr. Good actually gave us a lot of statistics, so I'm not going to repeat all of those statistics, but the ones that really hit home with me, suicide is the second leading cause of death among nation's teenagers. That is unacceptable. 1 out of 5 youth report seriously considering attempting suicide, and 1 out of 11 have actually attempted suicide. Something has to change.
Can you a little more
Okay.
closely?
I'm sorry, I'll speak up. So the pandemic is just one of those factors. There are other factors that we can look for. A previous existing mental illness is something that we need to be aware of. Stress and loss. Our teenagers are stressed out. Look at how many people they have lost through COVID. So they're going through a lot. Tiffany talked about ACEs. Well, we have new ACEs with the losses from COVID, but just a lot going on there. There are subgroups that are here that have an increased risk factor. That's our LGBTQ population, people in juvenile justice system, child welfare, and then we won't even start with bullying. We see an increase in cyberbullying with the social media access. But all of that to say, there's some good news. This is preventable. That's why we're here. That is why you are here. We need to do something to help prevent this. And the way we do that is recognition and treatment. You know, you recognize the signs and symptoms, and then you get them in for early intervention, for early treatment. You can prevent access to lethal means. We don't like to talk about that, but if they don't have access, then they can't complete it. Culture and climate in schools, we'll take that ownership. We have to improve the culture and climate in our schools. Kids have to feel welcome and feel like they are heard and understood. So as for interventions, when we talk about what interventions we can all provide, ask the question. There's this myth that if you ask somebody, are you thinking of killing yourself, that it's going to make them want to. That is not true. What that is going to do for them is it's going to make them feel heard. It's going to make them feel like you care enough to ask them, are you okay? Are you thinking of killing yourself? It's hard. Try it when you're out of this room. Try saying that a couple of times to yourself. Take comments seriously. When a child is making these comments on social media, to teachers, to you, if a school calls you and says, your child is making these comments, please take it seriously, because I assure you, we do. Increase coping skills. We've talked a lot about that. We expect these little humans to have all the skills they need from the time they're born that we have taken all of these years to develop. They have to learn how to accept failure. They have to learn how to be sad. They have to learn, what do I do to make myself more resilient? When do I need a bubble bath? When do I need to talk to a teacher? When do I need a hug from my mom or dad? These are things that are learned, and they learn from us at school teaching them skills, and from parents modeling, and from the community, from church, from anywhere they go and they see people. When they're in Walmart, they learn this is how people react. This is how people are resilient. At least they need one caring adult. I cannot emphasize how much one caring adult who will listen to them, who will hold space for them, can make a difference in a child's life. Just one. And then emphasizing with them, you are not alone.
Thank you.
I could just add to that. Sorry to jump in. I just so resonated with what you just said, and it reminded me growing up, one of the things that I experienced was when you're sad or when you have those big emotions, people are very uncomfortable, right? With big emotions. Oh, you're fine. You're okay. It's all right. Don't cry. And I remember even like during my childhood, that's what I heard. And not until later in life did I realize, well, that's probably not the best approach, because it puts a Band-Aid on something and it doesn't allow the child to realize it's normal to have emotions. And if you don't practice processing them out, you won't know how to process them out. And so one of the things that we teach our parents and our families that are open to us is, if someone's crying, it's okay to be sad. Let's talk about it. It's okay to be upset. It's okay to be angry. It's never okay to hurt yourself or to hurt someone else, but let's talk about it. And I can tell you just from personal experience, what a world of difference it makes for the child's ability to regulate if they know they have permission to feel those feelings. If they know that you're going to validate that you're upset over this thing that maybe I might think is small, but to you it's not, and that you're validated in that feeling, right? I'm not going to make you feel small because of that. And so I can tell you just from watching the kids that we serve and the kids in my home, it's a world of difference when they have permission to feel and when you help them navigate their feelings like you would want it to be done for you.
Yeah, great points, Tiffany. And as you're talking, I was just thinking about when I got the opportunity to observe one of our foster caregivers, who's one of our A++ foster parents. And she had a little 6-year-old girl that was really upset about something, and I don't even remember what it was, but the moment that foster parent took with that little 6-year-old, she got down low, eye level with her, talked to her. She labeled her feelings. You're upset and you're sad. And so she validated her feelings and she talked to her about that. And I was like, that's what we need, right? And I think that sometimes we think about with mental illness that we have to send the child or the young person off to someone to take care of these issues. But the reality is that there are healing moments in everyday life. And there are spaces that every caregiver, every safe, stable caregiver can give to their children, but we have to make sure that they know what those tools are, right? Because none of our kids come with that instruction book. And a lot of resources are out there that can help with that. Christie, did you want to talk a little bit about the early signs to look for with regard to suicide prevention?
Sure. So some of the things you need to look for are unexplained changes in behavior. It's not when a teenager does something that a typical teenager does. So you're looking for something that is typical for that person. So if you have somebody who cries all the time, then excessive crying would not be something that you'd worry about. But if you have somebody who you know never cries and suddenly they're uncontrollably crying, well, that's a change in their behavior. So that's what you want to look for. You want to look for changes in behavior, changes in eating, changes in sleeping patterns. You want to look for withdrawal from friends and activities, things that they've always loved. So if a child always played sports and they switch sports, that's not a concern. But if they've always loved sports and suddenly they have no interest in doing any type of physical activity, that's a warning sign. You want to look for lots of physical symptoms. Sometimes mental illness will come in the form of stomach aches, headaches, excessive sleeping, academic difficulties. That is just one of those signs. And then another key is when they start giving away some of their prized possessions. Generally speaking, there will be something that will give you, there's usually warning signs. It's difficult to say that because when you say there are warning signs, people who have experienced the loss of a loved one will say, well, I didn't see any warning signs. Sometimes you won't. Maybe you're not the one that would have seen them. So just, I say that, but I don't want you to take that to heart if you have somebody that you have lost and you did not see the warning signs. There are warning signs out there, just not necessarily ones that you have seen.
Okay. Tiffany, did you have anything else you wanted to add to this segment?
Sure. Thank you. Whenever we think about suicidality, another term that comes up a lot is non-suicidal self-injury, right? So we hear that a lot. Sometimes you might think of, cutting or just injuring your body. So as a licensed mental health counselors and also as, psychiatrists, all the time we're assessing for suicidality and lethality. And I would say those two are not always connected. So we have children and adults sometimes that engage in non-suicidal self-injury, and that's not necessarily indicative of, I want to die, right? Non-suicidal self-injury is not a diagnosis. I believe that it's a symptom of anxiety, of depression. And so when you look at that, the feedback that I get many, many times from caregivers is, oh, that's just attention-seeking behavior. Now, I would challenge you today, right now, in your heart and in your brain, to replace that with, no, that is connection-seeking behavior. I am yearning and I am desperate for someone to see me, for someone to validate how I feel. I need to connect to someone. And I see that as someone in pain, right? Someone who is healthy, someone who is thriving, someone who's connected. They're not going to engage in non-suicidal self-injury, right? That's someone who is hurting. And so I would definitely encourage you, even whenever you speak about this subject, be mindful, because you may think, well, that's just semantics. It's not. If someone hears you talk, it could be the difference between they see you as an ally and they see you as a bridge to recovery, or they see you as someone who's not going to understand where they're coming from. So I would say definitely understanding the difference. And this is not attention seeking. This is connection seeking, right? And then the other thing with PTSD, I'm thinking about trauma. A lot of times, these thoughts will come up, thoughts of suicide or thoughts of, I just want the pain to end, because what people go through is very difficult sometimes. And I will tell you, there is such a gravity to being trusted with information when someone tells you about their trauma or someone tells you about their hard thing. But sometimes it's that, oh my gosh, I don't know what to say. They just told me this. And then there's that, the Southern way of, let me just close this up. Let me just put a Band-Aid on it, because you're making me feel uncomfortable. And now your situation has become about my discomfort. And so I will say this, I've learned, in my heart and in my life, the way that I typically respond is validating what they've gone through and really helping them walk through of, yeah, this happened to you and this was terrible and this is not your fault, but you are strong and you are not alone and you are capable of recovery and you can move from a victim to a survivor to an overcomer. So speaking that life over that person and not trying to take away their journey, but equipping them to go through that recovery journey of, you are strong and you are not alone and you can make it to recovery.
And I'll just add to that. And I always like to say, and thank you so much for telling me that. If somebody comes to you and shares that with you, what does that say about you as a person? That child trusts you. That child has just shared something they've probably hidden, their deepest fear that someone's going to figure out that they're not perfect and that they're not okay. So if they come to you and they share that with you, thank them for doing so.
Dr. C, anything to add to this segment?
No, they hit it right on the head. It's all about validation. That's really what it comes down to. And just being present in the moment, making sure that your interaction, you're there and you're understanding, and you don't have to give solutions. That's one thing that often folks will think, well, I have to give them an answer. I have to tell them what to do next. You don't always need to have a solution for them. Being present and validating them is so much.
Absolutely. Thank you. So, as we're thinking and talking about suicide, it can be really scary, right? And I want to make sure that everyone knows that there are a lot of resources that are available. Many are available in the community, and we're going to talk about that, but there are a lot of resources available online as well. Just last week, I was in Orlando at a behavioral health innovation summit and learned about some things that I didn't know about either, and some wonderful free and low-cost resources online right now related to suicide prevention. And so that's on one of the handouts in the back of the room. But one of those that I found out about was the QPR. And this is a suicide prevention that's a free online training. It's about a couple of hours long. And it's really not just for professionals, it's for parents, it's for teachers, it's for anyone who interacts with youth. And actually it's for adults too, so I shouldn't just say that. But it's similar to kind of QPR or CPR or the Heimlich maneuver, right? Those are things that average people are taught how to do to help save lives. And so QPR, which stands for question, persuade, and refer, is one of those resources. And it's available. Again, you can sign up. I've got the website on that sheet in the back of the room. And another one is our mental health first aid. That's another one of our resources that's available that we're going to talk about. But I really encourage anyone who's online, watching, or in the room today to take these resources with you and have them and get involved, go through that 2-hour training before you need it, right? This is about prevention and early intervention. So for our panelists, what resources are available to parents and children who are experiencing a mental health challenge? Dr. C?
Sure. So what I'll talk about are mental health emergencies. So if there's an emergency going on, it's crucial that whoever's there either call 911 or bring the child to the closest emergency department for an emergency evaluation. So what is an emergency? Suicidal ideation, especially with a plan, is absolutely an emergency. Any bizarre behavior that's an acute change from kind of how they typically are is also an emergency, as well as any agitation or aggression that can't really be controlled with the measures that have been implemented or are done at home. All three are definitely considered emergencies and should be treated as such, and they need an emergency evaluation in an ER as soon as possible.
Thank you. And Christie, what about resources available in the schools, and how are teachers identifying needs, and how are the schools communicating with parents?
Sure. We've got half of all mental disorders begin by the age of 14. So your schools are an important place to start this. So thank you for bringing that up. We have several mental health professionals that are available in the schools. We have school social workers, we have school psychologists, we have mental health facilitators. So did I leave anybody out? School counselors, I am so sorry. So we have those 4 that are available in the schools at all times. We also have this new program called Hazel, which is virtual treatment. So parents can log on at home for their kids, or the kids can log on at school. So there is lots of access to mental health supports in the school setting. The way we communicate with parents, often we have mental health teams now where all of those professionals that I just told you, the mental health facilitators, school counselors, school social workers, school psychologists, got it that time. They meet together and discuss anything that they might observe, any students they feel are at risk. They look at all those factors, including discipline, including attendance. And if someone is at risk, they feel, then that team will communicate with the family and offer resources. We also, our social workers can go out to the house as well and provide resources and support for parents who are in need of that. And I think that's, and how to teacher training. So we have to figure out how to get teachers to identify, how do they know when to refer students? So we do youth mental health first aid training, which teaches, and every person in the school district is going to be trained in youth mental health first aid. We train thousands per year trying to get everybody trained to identify signs and symptoms of mental illness. We also do suicide prevention lessons with teachers. And then we started a trauma-informed classrooms initiative just to help our teachers learn how to handle some of those children who are unable to self-regulate. So that's what we as a school district are doing to kind of help combat this.
So quick follow-up question. So if I'm a parent and say you've got my middle schooler and someone at the school identifies some concerns, how would you communicate to me? What could I expect from the school system if I'm a parent?
Sure. You would expect a phone call from one of the mental health professionals who would say, you know, Johnny's experiencing these symptoms at school. Are you noticing the same thing at home? Can we have a meeting and sit and talk about what's going on and what kind of supports we can provide as a school district? We would offer either individual counseling. We have a lot of groups going on. We do drum beat, which is social emotional learning using rhythm, using drums, which is awesome because kids like to do it. They come in and they talk about their feelings while beating on drums, which, you know, serves 2 purposes, gets rid of that aggression, and it helps us to get them to open up to us. So we would just offer that. And if that is not an option, then we do offer community. Say, you know, is there a community provider that we can send you to? We really want to make sure that we wrap them with support, whether it be at school or at home.
And so if that situation were flipped and I'm a parent and I'm noticing something about my son or daughter, what should I do with regard to engaging with the school about that?
So if a parent has a concern, they call the school and they can talk to the school counselor. Once they talk to the school counselor, that will be brought before the mental health team who gets together to figure out we always want to make sure that we are working together as a team because there are so many supports in the school system. We want to make sure that we are discussing that and figuring out the best way to benefit that child. So a parent just needs to call and talk to the school counselor, and then their name would be on the list, and then they would meet with them and determine the best plan of action.
Excellent. Simple and streamlined, right? That's what we got to go for. Okay, so Tiffany, do you want to talk a little bit about the resources that are available through Peace River Center and other organizations in the community?
Yeah, so a lot of times children, as Dr. C mentioned, we see maybe mental health diagnosis like on the radar for kids around school age, kindergarten, first grade. Now, typically, when you think of, normal childhood development, this might be the first time they've ever had to sit still in a class, right? And so it might be very difficult to even recognize, well, maybe my child might be having some atypical behavior because they've never been in a situation where I would maybe notice. If you've had one child, you've had one child. If you have two children, you have two completely different children, all right? And their behaviors might be completely different. And so it starts over every time. And so what we see a lot is maybe a parent or a caregiver might have an inclination, once that child starts school, they might see some difficulty with attention, or they might see some difficulty just regulating. Sometimes it starts with a PCP. So they go in and they meet with their pediatrician, and the pediatrician is a wonderful start, a wonderful resource. For Peace River Center and for most mental health agencies, you start simply by picking up the phone and calling and scheduling an appointment, right? And so if you've never received mental health services before, you would have an intake with a licensed clinician. They would assess, they would see what's going on. And then from there, you and the provider would make a plan. Do we want to try outpatient therapy? And you try that. We always want to go from least intensive to most intensive. Sometimes you start and you say, these symptoms, this anxiety, this difficulty focusing is so great that I can't focus on coping skills or therapy because I just can't make these symptoms smaller. And so sometimes there's that conversation of medication management simply to reduce the symptoms so you can focus on functioning, right? That's not for everyone. Every single person needs an individualized plan that's best for them. And every person needs their combination of what works for their regulation. If outpatient therapy is not conducive, if it's not that level of need, then you go higher. We have lots of community-based services. We have therapy teams that go into the home. We have therapy teams that go into the school. We have intensive therapy that meets multiple times a month. We have group therapy, and then you would just go from there. The higher levels within children's service is called the CAT team, the Community Action Treatment Team. And that is really our last effort to keep that child in a community setting for treatment. And we will wrap around that family. You have an APRN, so meds provider, you have a nurse, you have a mentor, you have a case manager, you have a therapist, you have individual therapy, family therapy, group therapy, and we wrap around that unit. Now, if that child is not able to stabilize in the community, right, because the most important thing is getting your child well, then we could look at pursuing residential treatment. Residential treatment isn't forever for children. It's a short-term residential treatment to really surround you with 24/7 support to reduce those symptoms, to create a safe situation for that child so they can return to the community. So there's lots of different levels, but we always start out at least intensive because we want to make sure that we come up with a plan that's right for you.
Excellent. Thank you. So that's a good transition, I think, to talking about what are those services that are available for those higher needs youth and who can make referrals for those types of services. Dr. C?
So for the higher need youth, so what I do is I'm an inpatient child and adolescent psychiatrist. What that means is I work on an inpatient unit. It's a crisis stabilization unit. So we will have children on the unit, usually because of a Baker Act. That, again, Baker Act can be initiated. Well, what a Baker Act is it's a determination that the child and adolescent or adults are an acute danger to themselves or others, usually due to major mental illness or a suspicion of major mental illness. This can happen before or after the diagnosis. Once they come to the unit, we stabilize them and get them back to their home environment, just like I said, as quickly as possible. The Baker Act can be initiated by a few folks, a few of them including physicians, mental health professionals, including physician assistants, psychiatric nurse practitioners, psychologists, social workers, and law enforcement, as well as judges, which is why, going back to what I said earlier, when it's an emergency, you call 911, because if you're not able to take the child or they're not able to go to the ED on their own, law enforcement is able to initiate a Baker Act, which results in them taking the child, and adolescent, or adult to the nearest hospital and being assessed within 12 to 24 hours by a psychiatrist. So that's the way to kind of move forward when there's an acute issue. And then from our standpoint at LRH, we've got a few things that we've got. the inpatient adolescent psychiatry unit, like I mentioned before. We also have consultation to the pediatric side, which is those coming into the hospital for medical issues. We do consultations there. And then we've got, I'm sure y'all have seen the construction going on by LRH with the big health and wellness center. So we're currently expanding services there too. So we've got a few things going on.
Excellent. Okay. And Tiffany, what about non-emergencies and referrals for children's services?
Sure. So when we think of non-emergency, the best thing that you can do for your kid is to reduce the stigma of mental illness, right? Of mental health. If you'll permit me, I'm thinking about my sister. Whenever she had just graduated from college, she went on an adventure to Montana, and she was going to work at this camp. And she is very talented in that she broke her ankle climbing up the stairs. And so she's away from home, no support system, no insurance, nothing, not even a car. And she advocated for her needs because she was in pain, right? And so she got a coworker at, can you take me to the doctor? They found a medical facility that treated her ankle. She got all the x-rays, everything that she needed to stabilize in an unfamiliar environment with no support system. She got, because it was a medical condition, right? And not only that, but when she went back to her employer, she was not shy to ask for accommodations because she literally couldn't climb the stairs, right? And so she asked for what she needed, and she didn't feel weird about it. And her coworkers, who she did not know, brought her food and brought her flowers and came and did her laundry, all those things that you need to function. Now, I want you to think about if that had been the Baker Act, if that had been a mental illness, if that had been, instead of a broken ankle, thoughts of suicide, right? Or an attempt of suicide. How many of us would have advocated with our coworkers, hey, can you take me to the ED for an assessment? I don't think I'm safe. How many of us would have, in that moment, been able to advocate in an unfamiliar territory to get the resources I need in that moment to treat my pain? How many of us would have gone to our employer and said, hey, I'm going to need some accommodations. I can't do this way anymore. I need some help. I don't know. How many of us would have thought, this person just experienced a hospital inpatient stay. I'm going to go over and make them a casserole. I'm going to go over and do their laundry. So I think the best thing that you can do in any situation is think about how you speak about mental health. Think about how you speak about mental illness. Think about, are you being a bridge? Are you burning a bridge to the people around you? Because you don't know what pain they're in. And so that's number one, how you speak about mental health. At Peace River Center and in the school board, we use person first language. We don't say, well, he's schizophrenic. Well, he's a drug addict. We don't speak like that. They're a person. He has schizophrenia, right? He has depression. She is struggling with anxiety. So remembering, no matter what, underneath those symptoms, this is a person who is hurting. That's the first thing that you can do. How you speak about mental health, you're either expanding upon the stigma or you're reducing it. But I think just looking at your kid, being present, being aware, listening, validating their experience, but being wise enough to know if they're struggling, being brave enough to ask for help. And you can ask for help with the school. You can ask for help in your community. There's lots and lots of ways, finding things that bring them joy. One of the first things that we do when we're developing a safety plan for our kids, what do you like? What's your hobby? What brings you joy? And we all have that list of things that deplete us and those things that fill us up. Just starting there, one of the best things that you can do is go outside, to move, to have good sleep, to have good nutrition, just those simple steps that build a really strong foundation.
Yeah, you bring up there kind of as you're talking towards the end of that about really the holistic nature of our well-being, right? Where the mind and body, it's one. And sometimes we find ourselves in our silos and talking about physical health or mental health, but really it's all one human being. And so all of that, comes into play, what nutrition, sleep, movement, right? I know that Dr. Bruce Perry, who's a child psychologist with the Child Trauma Academy, always talks about what are you doing to have rhythmic, repetitive movement in this child's life, because that's something that happens very frequently in normal development, but sometimes it gets missed. And so we have to go back and try and recreate those opportunities for enhancing the development. Okay, so I'm keeping an eye on the time, and I do know that we want to, I think, open it up for some questions here. but I want to check in with my panelists. Anything else that you wanted to add from our kind of prepared remarks and prepared questions that we haven't covered? I know, Tiffany, you kind of segued there into the talking about stigma.
The one thing I would just add is that start now creating a routine of communicating with the people in your home, right? Because as Christie mentioned earlier, like what an honor for them to share that hardship with you, to share their trauma with you. But before the trauma happens, before you're in crisis, create a routine to where you're communicating every day. When I get home, you know, we have dinner at the dinner table and I say, tell me about the best part of your day. Tell me about the hardest part of your day. When I'm checking in with my clients, I say, tell me something that you're so proud of yourself for today, because you want to already have that system of clear communication in place to where when they have those hard days, they know you're safe and they know that you can handle their big feelings. One of the things that we always teach our caregivers is it's not your kid's job to be responsible for your emotional needs, right? Your kid is not your support system. It's your job to be strong enough and responsible for their emotional needs. So they should dump out their day to you, and you should have the emotional margin left over from your day to be able to help them navigate. And if you don't, you're human, right? So then take a moment and look and see, how can I build back that margin? Because sometimes I get home at the end of the day and my brain is so full and it's so tired, but I've got little kids in that room that they need me. And I've got to use my own self-care ahead of time to where I know that I have something left over for them, right? So take care of yourself, because if you cannot take care of yourself, you won't have anything left to take care of anybody else.
Words of wisdom. Christie, you're leaning in.
Well, she just took mine. I was going to say, self-care is so important because they are draining, you know, being with students all day, being with your own children all day. You have to put on your own mask first. You cannot give what you don't have. So we're constantly telling them to take care of themselves, you know, eat right, make sure you get lots of rest. If you are not modeling those behaviors, you're not teaching it. And if you are not participating in those behaviors, you don't have what you need to give to someone else. So please take care of yourself, listen to your body, and be when a child opens up to you, you can be ready to help handle whatever it is that they bring to you.
Thank you.
And just again, appreciating y'all being here, you know, having folks here that are interested in trying to figure out how we can help the kids in our communities is really, really important. And knowing that all of our goal, no matter what level of care it is, what level of involvement we have in children, the goal is for children to do better, right? It's not about having a diagnosis or the medication they're on, but the goal is ultimately for children to function better. And appreciating y'all taking the time to get more information, try to understand this a bit more, and we're always here to help.
Thank you. So as you mentioned that goal of helping our youth to get better and to function better, I know one of the challenges that frequently bubbles up is helping teens. And so I want to kind of shift to a little bit older child, you know, our adolescents, and talk a little bit about that. And are there any things in particular that parents can do? Obviously, the teenage years can be challenging just because of the developmental stage that brings, right? But are there any particular things, words of wisdom or advice for parents who might be struggling with behaviors of a teenager in their home?
So from my standpoint, again, I see children who come in crisis and struggling and having a difficult time for whatever reason. But my first question is never what happened or what's going on with you. It's more, tell me about yourself. What do you enjoy? What do you do for fun? What are you proud of about yourself? Getting to know a child and opening that up opens that lane of communication. And that's very, very crucial. And so that's the biggest suggestion I could give out there is focus on strengths, focus on positives, because you want to build on that, not focus on the negative.
Excellent. Yeah. Communication is the key, right? Relationship and communication. There's actually a website called the Center for Parent and Teen Communication. And you can sign up for daily emails from that center, And it's just very short, maybe 100 words or less, topics about parents and teens and how to communicate. I highly recommend it. I oftentimes read through that during my busy day, and it just helps me to refocus a little bit and think about all of the parents in our community that we're trying to help and support. And some of those, they always have a link if you want to get a little more information and dive a little deeper into it. But just even the little quick blurb that takes maybe a minute to open and read will help to give you ideas about that communication with teens and how to, approach different things with teens that can be challenging. So we did have some questions that had been sent in prior to the panel, and I just wanted to touch base on a couple of those. With regard to the youth mental health needs in Polk County, how would you say that that has changed since the pandemic? Does anyone want to jump in on that one?
At Peace River Center. So as the Director of Children's Services, the programs that I supervise are targeted case management, right? In-home therapy, community-based therapy. I see a decreased engagement in social activities, right? So there used to be, and there still are in some capacities, lots of opportunities for connection, lots of opportunities just to be together, because so much of our problem solving and our brainstorming and our regulation, we learn from peers. And so I would say since COVID, that's dipped significantly, and it's coming back. Summer camps are opening, and schools are face-to-face now, and all of these things, but we're still regaining ground. And we also still have teenagers that became teenagers right when COVID was hitting. So they don't have a historical experience of that socialization to fall back on. Like my son, included, he just turned 5. He does not understand what it's like to go to any type of school setting before COVID, right? My daughter, who's in 2nd grade, the spring break of kindergarten is when COVID hit, and she never went back until this year. And so she's learning. I'm thinking about her development. She's a year behind in socialization because they were robbed of that. So I think having parents understand we're in a season of regaining ground and adjusting their expectations, and even going back to what Dr. C said, understanding that there's a natural progression in adolescence of autonomy. There's a natural change, through puberty. So really realigning your expectations with what is appropriate now, because it's going to be different than what before COVID was. And I think realigning and adjusting, but also supporting, right?
Yeah, and I think one of the upsides of the pandemic is we realize that we really can do a lot virtually. So virtual training, telehealth, that helps us to open up opportunities. It might not be for everyone, but it can be very helpful. And we have seen with our youth in the foster care system that in some ways they're more comfortable using the telehealth options for psychiatry or even for ongoing counseling. But some of the online resources that you find out there, we used to think we all had to come together for training, right? But now you can do It's Time to Talk training online or the QPR training online. So these are really some great resources that are available that have evolved, and I think in a good way. One thing I want to just shift and talk a little bit about, the panelists and I, we were talking prior to getting things kicked off. And then I kind of connected some of that back to Scott's presentation and about engaging high-risk communities. And so one of the things that we were talking about was recognizing the power of people with lived experience and recognizing the power of someone who's walked in your shoes before and how they can help relate in a way that someone who hasn't walked in those shoes may not be able to relate. So Tiffany, I would want to see if you could share a little bit about where those opportunities are for peer support in our community, what organizations, what types of opportunities are out there that will allow our parents and our youth to recognize that they're not alone in this, that there are others that have walked in these shoes, and how those individuals might be able to help support them.
So with our adult clients, Peace River Center has a wonderful department for psychosocial rehab, right? And so it's actually very close to here. We have our Gateway facility, we have our Clubhouse facility, where if you have adult clients, you go there and you learn about your mental illness. Just because you have a diagnosis does not mean that you're automatically an expert on all things related to your diagnosis. You need to learn. And so I think it equips those clients with knowledge and power and understanding, but also a sense of community. For some of our adult programs, we actually have positions on the teams where it's called a peer mentor, where you have lived experience and you can come alongside that patient and say, been there. Let me show you what it's been like for me to walk through that. Now with kids, it's a little bit tricky, right? Because we can't employ kids. So what we see a lot that works well in that capacity is group therapy. So we have a lot of opportunities where, we work with kids individually, we work with parents individually, and then you can bring the parents together. The CAT team has a program where we bring the kids in and we do group therapy, but then while the kids are, participating in group therapy, the parents are participating in what we call parent cafe, where you have that same sense of, yeah, we're in this together, and let me share my struggles that maybe I didn't realize anyone else was experiencing. And we get that sense of validation, but also that sense of community. We also have other programs that provide group therapy in schools. And I think that you get that sense of, oh, other people have these same symptoms. Other people have these same obstacles. But look how that person is flourishing. Look how that person is thriving. Look how they've, taken hold of their recovery. I can do that too. So we see for kids a lot in that group therapy component. And then for our adults, we have lots of other programs that really provide that sense of peer support.
Okay, thank you. All right, I'm keeping an eye on the clock, and I'm going to be bold and say I think we've got a couple of minutes for a couple of questions. So do we have anyone in the audience here that has a question that was not addressed? Yes. Okay, I'm just going to repeat that question for the people who are watching from home. So we have a question about experiences in working with college students who may be experiencing some mental illness issues, some symptoms, and just some isolation feelings.
So glad that you're here. Welcome, Southeastern University. I'm an alumni. I'm so happy you're here. Southeastern actually invited Peace River last year to go in and train all of their RDs on mental health first aid. And then we actually just finished 3 weeks in a row of training all of their RAs. And so I think they're really getting a jump start on equipping their staff to look for and identify signs and symptoms of mental health. So way to go, Southeastern. And I will say the first thing is being aware so you can support the people around you. But college is a weird time. It's kind of like an incubator, right? So you're dealing with, general feelings of homesickness, general feelings of anxiety, and those are typical for that particular situation. What we find is there are strong correlations between the first episodes of psychosis and those first years of college, because no one knows you. Your coping skills are different. Your support systems are different. So it's kind of the perfect storm to where if there is a predisposition for psychosis, well, that is a good time for it to happen with all of these other risk factors in place. So the really exciting thing for Peace River Center is that we just launched a new program called On Track. And On Track specifically focuses on that group of population where there's that first episode of psychosis. And so we don't want to wait for symptoms to be pervasive. We don't want to wait for symptoms to be so severe. Let's be proactive and preventative if possible. And so to answer your question, I see a high level of anxiety, a high level of depression, but also a high level of, I don't know what the first step is to get the support I need, because I don't even realize that I need help because everyone around me is struggling to a degree. And so equipping your staff is a wonderful step to just be that level of support, but also expressing just general mental health information and psychoeducation on campus so people realize, oh, I'm not alone. That's me, and I can get help.
And I am also aware at Southeastern University that there's been a lot of education for the faculty members on becoming trauma informed and recognizing the impacts of trauma on development and behavior and functioning over the course of a lifetime. So they really are doing some outstanding work there. Christie?
And just teaching advocacy skills, because you're not away, they're away from their family, they're away from their support system. Just teaching them, not just psychoeducational, and this is where you get help, but it's okay to ask for help. It's kind of like Tiffany was saying earlier with physical health. We always reach out and say, I need a doctor, but we're too hesitant to reach out and say, I need some help for my mental wellness. So just teaching them that that's okay.
Okay. One more question. We've got a mic coming for you.
Oh, thank you.
Thank you.
I have a question. I currently have a situation that I've been a guardian for a long time, never run into a child who's handicapped, who really, really needs help. He's not getting much attention from the school. He has a low IQ and inability to speak. He can hear, but he can't speak. And he's been in classes. And I don't know that there's anything for him. Anybody who can evaluate, who can, there's no place for him to go. We've been trying to place him in another school. Nobody has the skills to deal with him, to deal with his speech issues. He can't read. He's 14 years old. He can't read. And I don't want to see this boy get tossed away.
Okay. I'm gonna be sensitive to time, so I'm not.
Yes.
Don't want to be rude, but I think I get your point. Which absolutely there are kind of subsets or subpopulations, for lack of a better way of saying it, of youth that have really intense needs. And they may have kind of a cluster of intense needs. And I really believe, and I'll let the panelists weigh in on this, but it's my opinion that what we have to do in those situations is just lean in and do the assessments that we can and look at this individual as an individual child and what are all of the needs that this particular child has. And we have to find ways to be creative to meet those needs, because there's not going to necessarily be a program off the shelf that is going to work for all of those needs. I don't know, panelists, if you have anything to add to that.
I would say you are an advocate for that child, obviously. So having those IEP teams come together in the school and be creative in coming up with a plan. And if it's not working, then you meet again and you discuss what's not working. You call in the experts, you get anybody that you can who's in the school system or outside of the school system to help support and advocate for that child.
Absolutely. And you don't have to advocate alone, right? We need to make sure that there's a team wrapping around and a group of people coming together that will continually advocate on that child's needs. So thank you. Okay, so we are almost at 10 o'clock. I want to go ahead and just wrap up very quickly and say a couple of highlights and high points. We know every child needs safe, stable, nurturing caregivers, right? We know that relationship is key. Healing happens in relationship. Relationship prevents serious mental illness. Communication. We really want to encourage everyone in our community to be opening up communication, whether that's in your family or in the school system, at work, opening up communication about mental wellness and what it takes. And we know that the environment has a huge impact. And if we can lean into that space and make sure every child has a safe, stable, nurturing caregiver, we can get ahead of this. That's the road to prevention, and that's also the road to healing. So I want to say thank you to our panelists. Thank you to our sponsors for bringing us all together today. And thank you everyone who has tuned in online and all of you in the room today. It's wonderful to see such a great audience and group of people coming together. So thank you. Ileana is telling me we're good unless you had any closing remarks.
I just wanted to add, I think there's a paper coming around for everyone to sign in. I think everybody signed in, and I have one favor to ask of all of you before you leave. Peace River Center also offers victim services. So we have a domestic violence shelter here in Lakeland. We have an opportunity to win $25,000 and all we need are votes. So on your table, there is a sign. It has a QR code. All you have to do is scan it. It takes 10 seconds to sign in and make a vote, or you can go to peacerivercenter.org/vote and make that